friends, welcome to this very exciting, innovative session on cataract surgery. I'm not sure what is recent in cataract, but we have to discuss something out of that. Whatever we are doing in cataract is recent only, because you can't do surgery which cannot be recent in human eye. And I'm delighted to have you people here. We have respected Dr. Naushir Sroff here as chairperson. Dr. Amamuti might join us. Our co-chair is Sanjeev Kumar Mittal. Where is he? I think he's going to join us very soon. Then we have Dr. Harsha Bahadur here. Dr. Sonu Goyal will join us. And I give this mic to now the dynamic leadership of AIOS and MOS, Dr. Anaga Harur.
Thank you very much, sir. Very good morning to all of you. I hope you have had a lovely day yesterday, the cataract surgery and the live surgery, and a night too. Yeah. So kudos to the entire team of AIOS as well as team UKSOS for putting up such a lovely show and having a scientific extravaganza. So in continuation of that, today we would be having this session on recent advances in cataract surgery. And let's begin with the first talk. Are all the speakers here? Dr. Deepa sir? Yes. Dr. Piyush Bansal is here. Ramurthy sir will come. Dr. Parul Chawla? Yes.
Only request is be on time so that we have time for a discussion.
Yes. Yes, please. AV team, please check. I would request the next speaker, Dr. Piyush Bansal, to please check his presentation if it's loaded on the other side.
A very good morning to all of you. Thank you, AIOS, for arranging this midterm in a beautiful place like Dehradun and making me part of this. My topic is pearls for the first femtocataract. We know it's a very much promising one. So it has got two parts. One is the femtosecond laser part, another is the manual part. In femtosecond laser part, there is docking, planning of the incisions, setting the parameter for the lasers, capsulotomy, lens fragmentation, putting the incisions, whether it is a main incision or side port, and if needed, we can plan for corneal relaxing incision also. In manual part, it's like a normal phaco, incision opening, OVD injections, capsule removal, hydrodissection, phacoemulsification, and cortical aspirations. So regarding the incisions, we all know incisions are executed accurately with adequate dimension, rapid healing, and there is less chance of SIA. Capsulotomy is very precise here. So nowadays we are planning for this, the premium IOLs, and it's very good to plan the premium IOLs. Nucleus management, the ultrasound energy is emitted very low in the phaco, can reduce the amount of fluid entry in the circulating eye. Excellent for premium IOL. But, there is a but, there are severe intraoperative complications may happen if there is loss of suction during any part of femtosecond treatment, so we may be in trouble. It may hit a pupillary margin, can cause complications. Some capsular problems are there. We have to be very careful for this capsular problem while removing the capsules. So it should be in a capsulorhexis manner, and sometimes you can see there is gas tamponades. They can cause posterior blockade syndrome, rupture of the posterior capsule, and the complications. Now I have a very short two cases. This is my first case, 50 years female with a grade 2 cataract. So everything was fine here. So while doing the incision, I faced some difficulty. So I had to enter with the keratome, then remove the capsule. Proper hydrodissection is very important here. So it will help cortic removal. So the nuclear emulsification is very easy as it has been done already. It's divided into parts. The most important part is the cortical wash. So you have to be very patient So here the rhexis margin is distinct, no capsular tags are there. So it takes a little bit time, and you have to give time for the cortical wash removal, and you can put the lens very effectively. Now this is my second case. Here it's a very soft cataract. The patient choose to do the femtocataract. Now here the hydrodissection was inadequate. The nucleus was so soft that I can't separate the pieces, or can't have a proper chop, or can't aspirate properly. But anyhow, with the very low parameters, just with a patient, I was able to manage the emulsification of the nucleus. Now the part comes, the cortical wash became very, very difficult. The pupil is getting down, and what to do? I have planned femto. I am not eager to put the hooks or the rings. So I thought I should put the IOL, then I will do the cortical wash. What is the rest is there. See, the haptics are attached. So I release it, tried the cortical wash, but it was incomplete, and I hurt the iris, there was bleeding. So at the end, my surgery was in very grief. Now for these types of soft cataracts, I usually prefer to do the flip, and I think this flip and chip techniques are more easier than the femtocataracts. It's very easy to manage. So the thing is, we should select a proper technique in respect to a proper case. So if there is a complicated case like intumescent cataract, subluxated cataract, posterior polar cataract, so we can choose for the femto, but not the easy cases when it makes difficult. We know life is about taking chances, trying new things, having fun, making mistakes, learning from it, but not at cost of patient's vision. Thank you so much.
Thank you, Dr. Deepa, for
Excuse me, what machine are you using?
Yeah?
Which is the machine you are using?
Centurion, sir.
No,
Oh,
femto.
yes.
Femto.
Catalyst.
Catalyst.
Yes.
What Dr. Noshiri was trying to highlight is, you have now different platforms for doing your femtosecond laser-assisted surgeries. But we have to really look into advancing your technique with your machine only, because you can't have all the machine with you. So whichever machine you have to expertise in those areas also. I think innovations, newer things which are coming in a femtosecond laser, it's been there for more than a decade now with us. I think one thing we desire is portability of a machine to your OR, rather than having a one single OR for a machine. If that happens, things will be easier. Incorporation of a phaco machine within the femtosecond laser device, that will also make things easier for a surgeon. And other innovation which are coming is live OCT, like when you are doing an actual procedure, right from the incision, the capsulotomy, nucleotomy, the OCTs will be live so that you know what is happening throughout your procedure also. And third, which is being practiced also now, you have a customized capsulotomy also, where your toric implantation can be easier because it gives you the customization of a capsulotomy in such a manner, it gives you orientation for your IOL implantation also. I think these are certain things which will make things simpler. As Dr. Deepa nicely highlighted, there are certain situations where it does have a huge advantage in a performing surgery, like a posterior polar cataract, wide cataracts, hard cataract, subluxural cataract. It can be advantageous for a surgeon. But if you compare the visual outcomes for a point of outcome wise, there would be no difference between a femtosecond assisted surgery or your phacoemulsification which you do in a conventional manner. So that, I think, we know that there is going to be not much a difference. But for patient point of view, it's a huge difference for them, because psychologically they feel they have gone through the advanced surgery, and that we should respect also. Yeah, Dr. Noshiri.
besides capsulotomy, do you really see any great advantage of femto over the regular cataract surgery? Because capsulotomy also they say is not as strong as a manual capsulotomy, because, and this is I don't know what Dr. Titia's view is, but some feel that the capsulotomy is as strong, some say that it's not. So is that a real great advantage also if you're quite confident in doing your capsulotomies? Whereas the nucleotomy is concerned, definitely it makes a difference in the total energy spent. But I would like the panel's opinion about the capsulotomy and how to get a good capsulotomy with a lower energy or with a higher energy. Some people say that the lower energy is better because the edges don't become very friable. But the higher energy only makes the edges friable and susceptible to tearing.
I think, Naushir, you answered your own question. I mean, the problem of the capsulotomy being weaker was more a concern with the earlier set of machines where, there used to be higher energy levels being used, and more importantly, there was a direct applanation of the cornea, because of which there were quite a few aberrant pulses, and there used to be a postage type capsulotomy. Nowadays, because of optimization, because of a contactless interface or a liquid interface, the focusing of the laser pulses onto the capsular excess margin is quite accurate, and the energy levels are also quite less. So there are, depending on who is publishing the study, there are claims that the capsulotomy twice as stronger as, but I personally believe it doesn't make too much of a difference. And let's look at it practically, whether you're putting endocapsular ring or whether you're implanting an intraocular lens or whether you are, stretching the pupil expansion devices, whether it's a rexis created by manually or by femtosecond, it tolerates all of it. And as a clinician, that's what matters to me. So I believe that, you're getting an accurate capsulotomy and the strength is good enough for all my procedures.
No, actually, this was aimed at people who don't have the machine and still feel that they are not, they are not up to doing a good cataract surgery. So that was aimed at that.
Thank you so much, sir. And we'll move on to the next talk. Dr. Parul Chawla, are you ready with your presentation? So as she sets up the talk in femtosecond laser, very nice talk, Dr. Deepa, but some of these complications, as you said, soft cataract, it can happen even with a non-femto. And even with a femto, if you have your settings of the phaco parameters right, then usually we don't, have these complications. So you can go back and just check on that.
Good morning all. I would like to thank AIOS organizers as well as the chairpersons, conveners and moderators of this session for giving me this opportunity. So I'll be speaking on enhanced monofocal IOLs, finding the balance. So this is a slide I took from ESCRS 2024 by Dr. Shiraz Dea, and he said that the range of focus is divided into 4 types. There are high performance lenses of 4 types, that is monofocal, monofocal plus, increased range of focus and full range of focus. So monofocal are the routine normal monofocal lenses. Monofocal plus include the enhanced monofocals like the Hoya Impress or the Isopure, or and the increased range of focus include IOLs like Vivity, and the full range of focus include IOLs like Panoptics or Geometric. So IOLs with EDOF characteristics, they can be pure EDOF IOLs, which can be spherical aberration based, or IOLs using the pinhole effect, or they can be hybrid multifocal IOLs with EDOF characteristics like the Techno Symphony or the Lucidus or the Synergy. So what is depth of focus? So these IOLs which I'm speaking about today, that is the enhanced monofocal IOLs, they don't follow the ANSI criteria. That is why they are not the EDOF proper lenses. They are not categorized as EDOF lenses. They are just the increased range of focus lenses. So what is the ANSI criteria? It describes the depth of focus as the dioptric power from the best peak of vision up to the defocus point for which the visual acuity is 0.2 logmar. So what are the clinical endpoints? Monocular depth of focus at 0.2 logmar should be at least 0.5 diopter greater than the monofocal control. And there are other criteria also of the ANSI guidelines. So the extended depth of focus, the pure EDOF IOLs, they like the IC8 has a depth of focus of around 2 diopters. The Symphony or the AT Lara has around 1.75 to 2 diopters, and the Vivity has of 2 diopters. But what are the limitations of EDOF IOLs? They can be loss of light, they can be halos, glares due to the rings, they can be loss of contrast. So we come to the enhanced monofocal IOLs, which don't have these characteristics majorly. So first is the Hoya Vivinex Impress, which has an asphericity of -0.18. It has a central optical element which creates variations in power that provides an extended range of focus. So it has a range of depth of focus or a range of focus of around 1.5 diopters. Then there is Eyehance by J&J, which has a negative asphericity of -0.27, which cancels the corneal asphericity of plus 0.27 exactly. And Isopure also has a similar asphericity. So the Vivinex Impress, it leaves behind a little bit of asphericity, so that that provides a range of focus. So I'll be coming to my surgery with an enhanced monofocal IOL. Increase the music. So this was a 73-year-old female with advanced intimacy. Just to show the audience that we can intimacy cases. We must use a soft shell technique of first putting the dispersive viscoelastic followed by the cohesive viscoelastic. Staining the capsule is a must in mature cataracts. I don't try to make an overly large capsule plexus, even in a mature cataract, because the IOL needs to stay in the bag. These were never editors. I used an exceptionally low IOP setting, which is very comfortable to the patient. If you have an active symmetry handpiece of a suture, then it is still better. I didn't have in this case. I use the stop and chop technique. The cortical matter is aspirated using a bimanual pathway. Followed by very thorough capsule polishing. So capsule polishing is very essential to prevent future PCOs. Then I inflated the bag, loaded the IOL. This is the injector system. This IOL went through a sub 2 mm incision, that is diameter was around 1.7. You can see the full frosted haptics of the IOL. This was an enhanced monofocal IOL, and it was perfectly placed in the bag, and the wounds were hydrated, along with injection of an intracameral oxyfloxacin. So to conclude, these enhanced monofocal IOLs, they give good functional intermediate vision. So the patients immediately, even on first post-operative day, they are able to read their mobile phones from a arm's length, and some amount of functional near vision. That is, they have a reduced near rad of about 1.5 diopters instead of the usual 2.5 to 3 diopters. And the modulation transfer function is almost similar. It is not exactly the same, but almost similar to that of a monofocal. There is no drop in distance visual acuity, no glare, no halos, and minimum compromise on the quality of vision, and high patient satisfaction. Thank you so much.
Thank you so much, Dr. Pavel. That was a lovely presentation. One of the advantages also over trifocals is in case you have retinal problems or other conditions which reduce contrast sensitivity, these lenses can be very well used. And with good micromonovision, you can give good near vision, functional near vision also. Any other inputs from the
The
chairperson?
only thing I would say is that this hardly requires any counseling. Unlike a trifocal lens, this hardly, you could switch over from a monofocal lens to one of these lenses. Your chair time doesn't increase by a second. And therefore you can comfortably give a person a very good quality of vision and also intermediate vision without the disadvantages of dysphotopsias and all. So I think the transition can be very smooth from a monofocal to an enhanced monofocal.
I think I agree with Dr. Naushad, and I don't even talk about mini monovision or titrating the power in the other eye, because straight away we have told the patient for near vision you need to wear glasses, 1.25, 1.5, whatever be it, varies from patient to patient, lens to lens. So essentially it's just intermediate and distance you are talking about, because visual needs of our patients are most often not near dependent. Their requirement for glasses is quite minimal. So the idea is to get excellent distance vision, fair intermediate vision, and reasonable near vision, and they are already primed to wear near vision, and it's just something extra. You give peanuts for paying peanuts.
Just one point like to here, these are modified monofocal lenses or enhanced monofocal lenses. 2 or 3 things are very important, You cannot directly, take 100% of people who are suitable for these lenses. A person who has corneal pathology, a patient who has undergone refractive procedures, you should always look the corneal profile there. If they have a lot of aberrations, these lenses are not good for those cases. A patient suffering from posterior segment pathologies, like people with advanced glaucoma where contrast is already poor, or patients with a macular degeneration, diabetic macular edema, surgeries. So you have to be careful before going for these lenses. Sometimes they can rebound back to you. In those cases, I think the simple monofocal lenses are very, very good, where you have no distortion of optics. So those things has to be looked into. Otherwise, for routine cases, this may be acceptable options as compared to the routine monofocal lenses. But normally we don't counsel them, patient coming, we are going to give you a good intermediate near vision. We just say this is a new monofocal lens. In that way, patient may not give you too much a problem. Yes, ma'am.
Sir, I have a question. Which IOL would an ophthalmologist prefer if he is also, he or she
That is a question.
operate?
Yeah, that I think that ophthalmologist himself or herself should answer that.
Also you have to answer.
So there can be
But
the
you
difference.
should be happy.
The panels of
You should be very happy by the time you are going to get the surgery done, new lens will be there. Or maybe you may not require intraocular lenses by that time also.
So
don't
there can be
don't worry
difference.
about that.
Sir, what would be your preference, if I may ask?
It depends on individual choice. Because as I said, in today's generation, your entire examination should have a good assessment of optics of your eye. That right from the cornea to your internal optics, that is the aberration profile. Then choose the lens accordingly. If my cornea has too much of asphericity, where I require a more negative asphericity to correct that, suppose I undergone refractive procedure before, I'll go for negative aspheric lenses there. So you have to profile that. You can't really go into that. I have asked this question to some of my retina colleagues, and I used to fear that if I put a multifocal in them, they'll have a difficulty doing indirect ophthalmoscopy, because the light is so bright there. Sometimes they have glare coming through that also. But
Yeah.
I have found that the people get adapted so fast. So some of my retina colleagues, they don't complain also. They do everything procedure. So it depends on surgeon to surgeon and person to person. Any lens is suitable for an individual. But given the option-
You just skirted her question. She is asking you which lens you will have.
No. If I am there, maybe I'll go for a pure monofocal lens, because that gives a best contrast possible in this earth. Because all other lenses are compromised in terms of contrast.
So I also agree with sir. There is no lens which is available which is 100%, which will give you the guarantee of 100% independent from these spectacles. So it depends upon it depends on person to person. So still, the choice of these lens can be, as sir has said, the monofocal eye.
So I think like an ideal
Because it
husband, there is no ideal lens. So, so now I'd like to invite Dr. D. Ramurthy, sir, a brilliant surgeon, great academician. He'd be speaking to us on clinical performance of next-gen toric IOL. Dr. Virendra Agarwal, sir, please load you.
Thank you, Anaka, and thank you, panel. I'm going to be speaking on clinical features of the next generation toric IOLs. I think all of us understand that to leverage the full potential of the toric and intraocular lenses, accurate alignment of these lenses is extremely important. You might have reservations about multifocal lenses, trifocals, EDOF, etc. But toric has come to stay, and at least 40% of my patients do get a toric intraocular lens. And we all understand that any significant deviation from the intended axis causes a deterioration in the quality of outcomes. Every 1 degree deviation causes a 3.3% reduction. It is said that more than 5 degrees of deviation is a matter of concern. If it's more than 10 degrees, it's a surgical intervention is most often needed. The primary toricity is also important, because if you have a 4.5 diopters of toricity, even a couple of diopters of deviation might cause a significant problem. One thing we need to understand is that when we talk about stability of toric intraocular lenses, we are most concerned about the stability of the toric intraocular lenses in the first 1 hour. Because most often, irrespective of the quality of toric intraocular lens that you're using, they remain stable 1 hour post-operatively. IOL rotation after 1 day post-operatively is less than 1%. So essentially, the important idea is to get the lens right there exactly in position and ensure that it stays in position in the first 1 hour. And that if you see the toric 1 and the toric 2 intraocular lenses from the Johnson & Johnson platform, they're exactly the same, but the toric 2 is said to perform somewhat better as far as stability of these lenses is concerned. It's simply because there is a difference in the haptics, and while a toric 1 has a smooth finish, the toric 2 has a frosted finish like this. And it is just a very simple manufacturing process. All these lenses are tumble polished. It was earlier, the optics and the haptics was tumble polished, but now what they have done is to introduce a small sleeve onto the haptics, so the haptics doesn't get polished and it's only the optics get polished. So the roughness remains, and because of this roughness of the haptics, there is greater ability to be rotationally stable because of the adherence to the fornices of the capsular bag, and this has significantly enhanced the outcomes as far as these intraocular lenses is concerned. And another byproduct of this is that, the PMMA lenses stick, the haptics stick to the optics the least, then the hydrophilic. The hydrophobic, all of us know the tackiness of the material has its advantages, but there is also a tendency for the haptic to stick to the optic very strongly. Because of this roughening up of the haptics, the tendency to stick to the optics is gone, and now it unfolds much faster. It said that the difference is about 0.25 seconds on an average, and faster adherence to the capsule of fornices again potentiates to greater stability of these lenses. This is a very short video of the intraocular lens. All of you have seen this, though you might not have noticed the haptics. You can see the frosted haptics in this, which is very clearly seen. And once you introduce this through your preferred technique, usually a 2.2, 2.4 millimeter, you can also see that it very quickly unfolds, and you are able to implant the lens exactly in the axis that you need, and that makes the lens remain stable. And 1 week post-operative mean residual error, a large study showed that a mean manifest cylinder for all eyes was less than 0.30 diopters. 84% of the eyes were within 0.5 diopters of intended cylinder, while 98.5% were within the intended dioptric power of 1 diopter, cylindrical residual power of 1 diopter. And an even more important thing is that when you are talking about highly myopic eyes which have obviously larger bags, the stability of these lenses does not change, and that's a very major plus point as far as the post-operative benefits are concerned. This is not just confined to the torics from the J&J platform. Even the Vivinex toric, which was alluded to just now, has a similar effect in which both the haptic surface, the anterior and the posterior sides as well as the edges have this frosted or the roughening, because of which there is enhanced stability. Actually, the Vivinex came up with this much before the Johnson & Johnson did this. Just because the toric 1 from the Johnson & Johnsons were not so stable, they had a potentiation to rotate almost 3 times as much as the Alcon torics. They came up with this modification because the stability of these lenses is much better. This is just to show you a Vivinex toric being implanted. As you can see, again, the roughened haptics. All of us have used these lenses, and this is just to show you the roughened haptics, and subsequently the propensity to stick to the optics is also much less, and greater approximation to the capsule of fornices and greater stability. The other important modification that is there, which has been around for a long time, is the design of the haptics per se, all of us know about the Acrisoft lenses coming with the stable force haptics. What exactly does it mean? It acts something like a finger with 3 folds. And in case you have a large bag, there is only 2 folds over there. There's a greater approximation. If it is shorter bag, say a 10 millimeter overall diameter bag, then it folds up like this because the approximation is there. And that's the reason these lenses are supposed to be quite stable. Another important factor is the stickiness of the material. And though all hydrophobic materials are supposed to be quite sticky, there is a differentiation between the different platforms. And the greater the stickiness, the Acrisoft material as well as the AIOCMT3 material is supposed to be significantly better in this aspect, because of which the ability to stick to the optics is there. In 2022-23, these are the toric lenses that I used, and you can see the Acrisoft IQ toric 615, Hoya toric 2265, and Technis 2 toric 417. The numbers were not so good when it was Technis 1. As you can see, all these lenses performed quite well, but I had to rotate these lenses 2.27% the eyes in IQ toric, 0.7% in Hoya toric, and none in Technis toric. It's a combination of circumstances that help. So essentially, to summarize, accurate alignment of toric and toric lenses is paramount importance, and we all need to understand that what we leave the patient behind on the table is most often what the patient stays with, because once you get the lens stable for the first 1 hour, that's the reason that we always patch these eyes post-operatively and remove the patch a couple of hours later. The lens remains quite stable. Frosted haptics mitigates this because of greater friction between the haptics and the capsule of cornices. Design of the IOL like the stable force haptics is an additional factor, and stickiness, the hydrophobic material, also helps. Thank you so much for your kind attention.
Yeah, thank you so much, sir. So, one more point was the Rayner EMV toric. That has the greatest contact angle if you compare the contact angle with the other lenses. How important is that? And it has the 360-degree Ammon apple edge also, which helps in better rotational stability. What is your...
Yeah, I think that's an important point. You know, it's not only the flexibility of the haptics, like in the stable force haptics, is also important, because you get capsular sizes right from 10 millimeters to 12.5 millimeters. And the haptics being flexible so that it can either shrink down or expand, at the same time being also rough, is obviously advantageous. So the reason I cover different platforms is different platforms have certain advantages. Maybe the lens of the future should have a combination of all of this.
Yeah, so we should actually give them this idea that so each has different advantages, but there's no one lens that has everything.
Dr. Ramamurthy, what about the Alcon? You said that you found more rotation with the Alcon lenses compared to the others. Although it's a very tacky material, and we have found that almost we have the least rotation in Alcon lenses, provided you remove your viscoelastic very well. So
Absolutely.
What do you feel about that? Because although these have a rough edge, but still the tacky material also makes a very important difference.
Absolutely. Actually, you know that there was a very significant study from David Chang which showed that the rotational stability of the Alcon torics is 3 times better than the toric one from the J&J. And that is the reason actually J&J went back, and then they did not alter the shape of the haptics, but they introduced the roughness of the haptics, because of which it was good. Even in my study, if you see, it was just 2.2% where I had to rotate these. That is, out of more than 600 eyes, 14 of them I had to rotate, which is per se a small number. But then going forward, I think even this can be brought down.
Also, Hoya came out with an overall diameter of 12.5 earlier, and then had to switch over to 13 millimeter diameter with a roughened edge to give it more stability.
Right.
So how many of the panelists see the patient again after 1 or 2 hours? So, I mean, all of us believe and agree that it rotates in the first 1 hour, but how many of us actually do it?
No, I don't check for rotational stability and all that. What we do is, obviously most of us do under topical anesthesia, and we don't patch the eyes. But toric and toric lenses, toric monofocal or multifocal, I always patch the eye. And once the patient has been given all instructions, is going home, about an hour or 2 later, either me or one of my colleagues takes off the patch and sends them.
So what we do in our practice is not only torics, but for all patients, we do refraction the next day immediately first day post-op. So I see the patient with full refraction. So if you see that there is a residual astigmatism, then you know that probably the lens has rotated. Then I dilate immediately at that point of time and see if it has rotated, then we go back and rotate it. We don't wait for a week or so to do.
Anaga, there has to be a set, protocol. Which are those cases where rotation would be needed? You can't really jump on every patient to rotation because criteria has to be set. So one of the criteria will be visual acuity of a patient. Second is the degree of rotation. Third is the anatomical configuration. If the patient has a myopic, big bag, loose bag, shallow chamber, any other associated problem, maybe a leaky wound, something, those has to be assessed before we think of rotation.
Yes,
If
absolutely.
my
If we
patient is
find
happy with the, even if there's a 10-degree rotation, patient has a better than 6-9 vision, patient says, I'm okay, why should we rotate? If patient has, I put a multifocal toric lens, patient has six past vision, but not happy. So I may have to consider rotation that despite having a 5-degree rotation. So each patient has to be assessed thoroughly, then judged. There's no requirement for immediate rotation in these cases. You can wait for a few days, a week also, because sometimes lens sets in the proper position also. To assess the case properly, then decide what is to be done.
The sweet spot for the rotation period is supposed to be 2 weeks. When the capsule is slightly fibrous, it's likely to remain.
Another point I want to add that always check on the slit lamp, the axis is actually implanted axis or not.
Yes, yes,
because there can
absolutely.
be surgery induced astigmatism, particularly on the day one because of the incision.
Yes, yes.
So don't do probably on first day.
No,
Better to
we
wait.
just see on first day, but then final rotation we go ahead and do after 1 or 2 weeks only. But at least we can follow up the patient properly.
then we know
We
that
have
this
some
requires
idea
a frequent
what is
I
happening.
think, as Professor Technical said, you should analyze the satisfaction of the patient. In the sense the patient is very happy, satisfied, why do you suggest that, you've got a little, you need a minor rotation and then put it into his head that he's got a lens which has got rotated a bit and then he doesn't know what is the rotation and he feels that something is very grossly gone wrong with his eye.
I think, sir, 1 or 2 instances I had to do immediate rotation, as Dr. Anaga said in day one, because by mistake, sometimes your orientation is distorted by your assistant. You would say rather than 180, I put it about 90 degrees, and that is an indication to rotate immediately.
Yes.
Or by mistake, there were 2 patients lying up, but you have exchanged the lenses. It has happened to me once or twice. That I had to take the patient, both the patients there, and change the lenses for them. Those mistakes can happen. Therefore, it is important for us to assess your patient on the table also. Check the power, check the axis, same patient, then implant. But especially when you have a larger number of cases piled up, you can have these mistakes also.
Any experience with Indian touring?
Yeah, I do
Yeah, use a lot of Indian torics.
Especially AIOCMT3.
Care group,
They
I
do
know.
wonderfully well.
Very well.
Wonderfully well. Even their trifocal lenses are so good.
Yes, absolutely.
Yeah. Exactly, you're right.
No, that was what I was alluding to. There is even a small experiment done when these lenses have been placed on a petri dish and you have a flush of water. The Acrisoft lens and the Acryol lenses tend to move much less than some of the other lenses. That shows the stability of these lenses.
Yeah. Over to you, Dr. Virendra sir.
Thank you, Naga. So we are having the 2 topics similar to the next gen IOLs. So I thought that I should go to basics. Dr. Ramurthy has done the clinical experience of the newer toricals. But my question is that why the torics are required? So that should be the question in your mind, because most of the what happens, those who are doing a new practice, the people are using torics are having their own protocols and system in which they come to know that this patient is fit for toric. But I am just addressing for the new people that whenever a patient comes to you for cataract surgery, always think, does he require a toric or not? There are different parameters by which people implant toric, that 0.75, 1, 1.25 or 1.5 diopter plus, then only they will implant toric. But my question is that you should have that in your mind, that is this candidate or this patient require a toric or is a toric patient? And then comes the question that to whom we should do toric and why we should not do toric in some patients. So the corneal topography or the surface is the most important in decision making for the toric lenses. Any astigmatism you don't treat, patient may not be happy beyond 0.5 diopter in my personal opinion. And particularly as sir said, Dr. T.L. sir said, for multifocal lenses, the astigmatism is the main culprit by which the patient says that I am not happy. So you need to take care of it, and Cataract is becoming a refractive surgery, and many of you must be doing refractive surgery otherwise in your own center or in some other centers. So preferably buy a topographer or have something to assess the topography. The another important thing is a dry eye. The dry eye makes the patient's happiness into hell, because the patient is having a dry eye and you want to give him crisp vision. And whenever we do toric or multifocals or a premium lenses, we need to increase his expectation. And when we increase the expectation, the patient expectation actually multifold increase. And why we need to increase the expectation? Because we need to charge extra than the routine monofocal lenses. We need to give more chair time. We need to have a more reimbursement from the patient. And because of that, because when we say that something is packaged like 40,000, it will go to 60,000, he said that something magic is going to happen. So be always careful to assess the topography. You can use topography, pentagram or eye trace or whatever we use system. Don't believe on optical topographers, optical biometry topographies that they are enough, because they just give very central zone, though it is good for assessing the amount of astigmatism is there. But in the periphery there may be irregularity which will give you poor vision, like a subtle keratoconus or formoplastic keratoconus may be missed on a just very 3 to 5 millimeter topography. Dry need assessment can be done by many majority of the instruments now, almost with full range of equipments available from 5 lakhs to 50 lakhs are there, so that can be done. Macular assessment is a must, and there is a controversy which way to assess the toricity, the manual keratometer, autograph keratometer, biometers or topographers. So I leave on you, and I have found that there is a lot of discrepancy, and that's why, as I said previously also, the patient happiness is really one. If patient is more than 6'9", don't try to do rotation on other things, because you don't know the actual axis. It may not be that regular also. So I just want to show you a small video in which the toricity element aligned. There are different ways to align. I use the bimanual cannula at the end of the surgery to tap it in the place, and I feel that is one of the instrument. The bimanual irrigation aspiration is the instrument by which you can end. So I'm just going fast forward. This is a routine. And I feel that all patients to whom you are implanting, this is just to show the frosting of the thing, and then I will show you simple surgery you all can do, and you all doing is a simple like other cataract surgeries. But at the end you need to do a line. You can use online marker, markerless surgery, or you can do a marking on a slit lamp or whatever you feel like for the axis alignment. And this is the way I rotate. Complete removal of visco behind the lens is a must. And as Dr. Ramurthy sir has said, is very clear that when we were using toric, the previous version from the J&J, the rotation was there and it was a significant one, and it was not giving the confidence to use in all patients. Definitely some of the rotations were requiring, and now with the new model this is not there. I do hydrosh on both sides of the all incisions, be it a side port or something, and this gives me a chamber in which you don't require to overinflate or to leave it shallow, and there is no need to increase the pressure, and this is how you can align the lens. That is very simple. Post-operatively, you can assess it on slit lamp, on eye trace or whatever way, and sometimes you require a surface analysis, and this kind of rotation, definitely, this kind of alignment definitely require rotation. There are a lot of papers in support of the new lenses, and I feel the new lens is having a solution for which we were suffering otherwise. Because of this simple change in keeping the surface of the haptic rough, it is having stability. And just to conclude, the toric is the need of the day. You can do online or on slit lamp marking. OVD wash complete is a must. Hydration should be proper, no hypertony. And toric is the design and innovation in which the patient's vision has really changed. Like just monofocal to advanced monofocal, but better development is this toricity, because these patients were really suffering the quality of vision. Thank you for this opportunity at AIOS and UK.
Thank you so much, sir. We have already had a discussion on this, so we'll move on to the next talk by Dr. S.K. Mishra. The next speaker, Dr. A.K. Jain, sir. Yes, you can please.
Here is. Good morning, everyone, and greetings from Army Hospital Research and Referral. So I shall be speaking on extended range of vision with Lux Smart Pure Refractive Optics. I don't have any financial disclosure. So we all know what is the requirement of a patient after cataract surgery, that he wants now good distant vision, good intermediate vision, and a good near vision. So the distant vision for driving night activities, the intermediate vision for laptops and work on playing golf, and near vision definitely for readings. So the answer is, one of the answers is EDOF lenses, where you get a good distant vision, intermediate vision, and a functional near vision. So the best candidates for these EDOF, that is Lux Smart lenses, that where you plan to do emmetropia. It's recommended that in Lux Smart you don't try a micro monovision like any other EDOF lenses. You plan for a emmetropia, where the patient, you plan for bilateral implantation if you have night drivers, photographers, and microscopic users. So what are the content where you should be careful is that the patient is very demanding. Please be very, very careful in demanding patients, because they have a lot of expectations, and none of the lenses can fulfill all their expectations. If you have a pre-operative astigmatism of more than 0.75, the option here is that one has to go for a toric lenses. We have toric Lux Smart lenses. If you have pre-existing corneal or retinal pathologies, if you have any intraoperative surgical complications or dry eyes, please avoid these lenses. So we know that how do you correct for presbyopia is either you can go for a micro monovision or go for bifocal, trifocal EDOF accommodative lenses or pinhole effects. So we know how it works, that it's an extended depth of focus, where it provides a range of vision rather than a single point of focus. So as by my previous speaker, it's already been given in detail what are the ENSI criteria for EDOF technology. Again, it gives basically it gives some degree of independence from glasses, giving a good intermediate vision and minimal impact on the distant vision. Gives a zone of vision rather than a single point of vision, and there is definitely a reduced halos and glare in these lenses, providing a sharp vision for the distance as well as intermediate vision. If you this in monofocal, this is the MTF of monofocal, bifocal, and EDOF lenses. EDOF lenses provide a good MTF for the intermediate vision, especially the Lux Smart. A brief on the Lux Smart lenses, that it's a different technology. That's a patented technology where it has got a center EDOF center, which is a 2 millimeter zone, and this is followed by a patented transition zone and a monofocal periphery. There are no rings in this. So the center part of these lenses, it uses the combination of 4th order and the 6th order spherical aberration of opposite sign, which increases the depth of focus by 118. That means it provides it's almost like 1.5 diopters of intermediate vision. There is a smooth transition of optic vergence from the center to the periphery, and this is how it attains the EDOF property of these lenses. So it's a monofocal, there's asphericity and aberration-free lenses, and it is a 4-point, that is, it's got a 4 haptics, so it's a 4-point fixation, and it's it comes in a preloaded form. It's a hydrophobic acrylic copolymer, including a UV absorbing material, which protects against the light that could cause a retinal damage. These are the properties of this Lux Smart lenses. The point of this 4-point fixation is that it prevents, it gives a stability against rotation, and especially when you're using a toric form of these lenses. Again, the advantages of preloaded lens, I don't have to mention in detail that it's easier, but I would, these are the videos, if you see this lenses, there are 2 different videos. So one, it goes in a very smooth manner, but this is one, if you see this, the edges, this is a very smooth, the edges, if you delay this lenses in loading and implantation, you can have these edges which will stand out for some time. Don't be scared of these, because ultimately it's going to go back, but it takes little time. And so this is my word of caution in this, that you, unlike any other lens where you know, your assistant, the moment you have done your, before the phaco is done and the lens is loaded, here you should not do that. You should load the lens when you are absolutely ready for the lens implantation, and the lens injection should be done in one go. It cannot be any delay there, so it has to be a smooth one. That's very, very important, because if you do that, if there is a delay, then you will have problems. So it's not a trifocal lens, so please do not say that patient is going to get rid of your glasses. It is going to give a functional near vision, and this is my data that I've implanted almost 148 these lenses, and in more than 95% of patients I've achieved 6/6 distant vision, 6/6 intermediate vision in 95% of patients, and functional near vision, that is in almost 80% of the patient the vision was N8, in 10% of the patient was N6, and 10% was N10 and beyond. This is the video which I was talking about, that the edges, you know, the optic edges, they tend to roll up a bit and takes little time for it to unfold. These, if you can see this, these are the edges, and this is how it takes little time for it to unfold. So the key advantage is that it gives a good distant visual acuity. There's a good intermediate visual acuity because of depth of focus, low dysphotopsia, tolerance to tilt and decentration, and a quick neural adaptation, increases the presbyopia management indication, and comes in a preloaded delivery system. Thank you.
Thank you so much, Dr. Mishra.
Dr. Mishra, I have one question.
Yeah,
for you.
please.
You mentioned that the intermediate vision by this lens is about 95, about in your patient it is 6/9. So you have drawn the defocus curve for these lenses, or
Yes, sir.
how you assessed?
We have drawn a defocus lens. We have done, I didn't, because of the positive time, I have not given my this thing, but we have a defocus curve with this.
So that is how we confirm the performance of these
Yes,
lenses,
yes,
because
it
until
does.
unless it is
Unle-
confirmed by the defocus curve,
Exactly.
it's very important
It does
to
with that.
plot the defocus curve for these lenses.
Thank you.
Thank you so much. We'd like to now invite Dr. A.K. Jain for his talk. Dr. Harshal, can please load your talk.
Thank you. So my talk is quite basic, and I'll be concentrating more on the IOL design, material, and rotational stability of the IOL. Does it really matters? Somebody was asking from the audience that which lens is the best one. So if you have a very strong platform which has sort of all properties which we have discussed, the rotation free, the best quality of vision, haptic doesn't stick together, goes through 1 point, less than 2 millimeter incision. So let us see how the VVLX platforms comes or graduates through all these attributes. These are my financial disclosures, and I will be mainly concentrating on this VVLX platform, what it is. It is, as you know, most of the aspheric lenses addresses only the spherical aberration. There is no lens available or platform which addresses the coma aberration, which is apparent in all the normal eyes, and it remains there after the surgery also. So it has a proprietary aspheric optic design. It has a hydrophilic activated material with a new delivery system which is very safe and easy to use. You can just inject the lens blindfolded. It prevents PCO as compared, much more as compared to the other designs available, and of course it has a rotational stability, and this is the VVLX platform. We will be discussing each property one by one. So what is this proprietary aspheric optic design? This optic in central 1.2 millimeter has a small area of positive asphericity, then a small area of negative, and then a large area of which is the normal aspheric negative asphericity of the lens. How it function is, this aspheric design is designated to minimize the impact of coma on the image quality. The central 1.2 millimeter zone, it produces a plus coma in one direction, and the second part, which is annulus of 1.2 millimeter, it induces coma in another direction. And when both combines, in case of decentration of the lenses, as we all know, all lenses doesn't center in the back. There is a angle between the visual and the optical axis. What it does is it improves the quality of vision, leading to almost a round point spread function. And this is evident in literature way back in 2018. This is a lab study which compared these three IOLs, the most common one, the Hoya, the Zeiss, and the Alcon, and it showed that a little decentration in these lenses decreased retinal image quality, least in the Hoya Vivinex IOL, Vivinex platform. But this is an experimental study where everything is aligned on the optical axis, but there is no clinical proof to it. And this was also proved that the Vivinex IOL platform resists coma to a greater extent as compared to the two other IOL. As you know, as the decentration of the lens increases from 0.4 to 0.7 millimeter, the amount of coma induced also increases, but it is much less in Vivinex platform. Also, the quality of vision decreases, the visual stereo ratio, which is the best indicator of quality of vision, it decreases least with the Vivinex platform as compared to the other two IOL. So these are the two proofs where we compared this platform to the other two, Alcon and the Zeiss platform. These are published studies. This we published in 2021, this in Indian Journal in this year, January. What these studies says that again, with the Vivinex decentration, actually there was an improvement in stereo ratio, which as you can see with this, it is decreasing. As the decentration increases, the visual stereo decreases, but not so with the Vivinex platform. And same is true with the techniques. Those are decentration of techniques, as we have heard from the previous speaker. The decentration in case of techniques is much less, but it has a large asphericity, 0.27 plus, because decentration is also leads to more deterioration of quality of vision if asphericity is more, which is more so in techniques. So with Vivinex, there is much less deterioration as compared to this techniques platform, where the deterioration of quality of vision is much more. So this we, as Parul has already highlighted, this is a very good multi-stud injector, as you can see, which has very controlled delivery of the lens. As you can see, either you can do a direct implantation, there is a small ridge, you can increase the length. The Dr. Parul showed the direct implantation, but you can also do a wound assisted implantation of the lens, and it goes through almost 1.8 millimeter incision, and there is no distortion of the wound. So this is the direct implantation, and there's a ridge. You can push it front and back and do your implantation accordingly. And it has a material which is almost all advanced IOL now, a glistening free material. So let us not go into detail, but it has a more square edge as compared to the other things. It has almost 90 degree, or the square edge is much more in this lens as compared to the other lenses. And along with this edge design and hydrophilic, this has a posterior surface which is ozone treated, and it becomes much more tacky material, and it also prevents the migration of epithelial cells behind the square edge, as well as posterior surface treatment. So this is what already a previous speaker has highlighted. It has textured rough haptics along with there is this is the textured haptic along with the frosting, which is the rough side, which increases the rotational stability of this lens. And also now the edge of the optic is also frosted, which also to some extent may prevent positive or negative dysphotopsia. So as far as rotational stability is concerned, Dr. Ramamurthy has already highlighted these lenses have all very good rotational stability, and in comparison this platform was again quite good, and over a period of time with this Vivinet platform we have different types of different types of monofocal, enhanced monofocal and multifocal IOL available on this platform, and recently this Impress was introduced, which Parul highlighted in her presentation.
Dr.
So
Jain.
this is the conclude. Yeah. So we have this is the only lens which has an advanced optic which try to neutralize coma and try to negate the effect of decentration on quality of vision, and rest of the points already highlighted. So that's about this platform, which stands out as compared to the other platforms in a way that it has a very proprietary aspheric optic design. Thank you so much.
Thank you, Dr. Jain. We invite Harshul. Our long-term results of Vivinex is now being published in AGO. It will come in AGO now, where we have looked into 3-year results of Vivinex lenses and looked at the YAG requirement in these cases, which are less than 3%. And that indicates the quality. Thank you.
Do you think because of this unique asphericity, would you prefer these lenses leave alone decentration if there is a large angle alpha? Would you prefer these lenses over the other lenses?
I think that study Arun had also done before. We have also done. This is a lens which takes into account of physiological decentration of these larger angle alpha cases, and maybe a better option in such cases also. And as he talked about the addition of posterior capsule towards the posterior surface of IOL, and we've seen in 3 years results, almost more than 80% cases, there's a direct addition of these capsule to the posterior surface of the IOL, and that prevents the PCO formation in these cases. And we're going to come with the second phase of study, which is already there, comparing with other designs of other lenses in terms of addition of a posterior capsule to the posterior surface of IOL. It happens with other lenses also, but it is more with the Vivinex Hoya lenses.
Those studies, if I can add, these studies we also try to center the lens on a coaxially sided center of the lens.
Dr. Harshul, are you ready?
Center of the bag and optic lens doesn't coincide. There is a minimal amount of build as well as decentration of human crystalline lens also. So the IOL also try to settle there in a descended position. So the position will be somewhere in between the geometric and the visual or a 1/3 to 2/3 distance.
Yeah, I'm ready.
Wait, on करो भी कोई आ गया रावताई हॉस्पिटल आ गया.
Thank you so much, sir.
हमारा दामाद है.
So, as soon as we see a case like this, a true post-polar cataract which has an underlying appearance like this, we know that we are on a deadly ground. And there's a high chances of opening up the posterior capsule in these kind of true post-polar cataract. So we always have to be careful at each and every step. So let's see what all is needed to be done. So coming to the sizing of capsular rexes, you know that size should not be more than 4.75 or 5 millimeter, because in case there is a big PCR and you're not able to put a single piece IOL in capsular bag, you may need to put a 3-piece IOL in sulcus and do optic capture. And for that optic capture, you need a rexis which is not more than 4.75 millimeters. We always avoid cortical cleaving hydrodissection, just hydrodelineation to delineate the endonucleus. And once you do that, you just go ahead and try to chop the nucleus. And once you chop and divide this nucleus, don't do much of the lateral separation. So our idea is never to put a pressure on the posterior capsule, just do little separation and turn your bevel to one side, chop this nucleus in like a piece of cake and take this out, turn it bevel on other side and take this nucleus. And by the time you do this, most of the time this endonucleus becomes mobile and you can take off this endonucleus, and what remains is, so essentially it's the layer by layer separation what we are doing as taught by Dr. Tityal sir also. So we just loosen up the entire epinucleus, try to loosen it up, and always maintain closed chamber. That should be the goal, because that's the key to success in these kind of cases. So once you loosen up the epinucleus and then you take this epinucleus, so we are coming to the last portion there. So this is the, so our idea is to try to delay and prevent the opening of posterior capsule as much as possible. So this is the last epinucleus sheet which is coming up, and once this central plaque comes off, I see that there is a PCR there. So maintain closed chamber. Just if you see the movements of posterior capsule like this, it's opening up, you know that there is of course a vitreous there. It indicates. So you just take off your chopper and put viscoelastic from side port before stopping your infusion and taking out this. Now our aim is to clear the entire anterior chamber from the vitreous, because unless and until we remove the vitreous from anterior chamber, we can't take off this cortical matter which is there. So I go ahead and stain with triamcinolone and do 2-port anterior vitrectomy. So once you finish off anterior vitrectomy and clear off entire vitreous from this anterior chamber and capsular bag, then you can take this cortical matter. Remember that PCR and vitreous coming out, the complications only occur when we don't manage them properly, and we don't have to put any traction on the vitreous, because that will give traction on vitreous base and that will cause long-term complication. So again, I'm maintaining anterior chamber before turning off irrigation, and now the entire vitreous is clear. So either you can use the same cutter on IA cut mode, or here I'm using bimanual IA. So you see, you can only strip this when there is no vitreous. So take off the cortical matter there. You can see there is a big PCR extending from this side to other pole. Again, before changing my hands, I'm maintaining closed chamber, putting viscoelastic. And then you change your hands and very meticulously you clean up the entire capsular bag. And these are the last pieces of cortical matter which you take out. And keep your irrigation cannula towards angles, not directing posteriorly. So again, maintain chamber, and this is a 3-piece IOL which was in the backup for this case. So once you load this 3-piece IOL, it's a little tricky to implant these lenses because haptic tend to come out in a funny way many times. So loading of the lens, so a small trick for that is just pay attention to the haptic, that it should always come out horizontally beneath the iris. So always try to keep it horizontal and then turn your wrist in anti-clockwise direction so that haptic doesn't pointed downwards. And then you put this IOL in sulcus. And after putting this, use Kugelin's hook to capture this optic. So again, go ahead and put some visco over top of the IOL and use Kugelin's hook to capture on one side, and then you can capture it on other side. So this is anti-optic capture. So rexes become like a shape of a rugby football. You can check on both the sides. So this capturing is needed for long-term stability of the IOL in the sulcus. So that's where the importance of sizing of rexes comes. And put some Miocol, and you just hydro-stitch all the incision. So this finishes the case, and I'll just show you the post-op photograph. You can see a through and through tear here, but the lens is nicely captured in the sulcus, and it's very well stabilized. See, another case, what I want to show here is that every PCR doesn't mean there is, okay, fine. Yeah, I think I'll stop it here only. Thank you so much for this wonderful opportunity.
Just a quick comment. Nowadays, we have made it a practice to do a OCT-based ASOCT, and we are quite surprised. We have done 49 eyes in the last 3 months or so. The number of eyes where the posterior capsule is completely intact. In those cases, we just go ahead and use it, do it like a routine cataract surgery. And it saves a lot of time, a lot of, it's much more controlled. We find that this sign has a very high negative correlation, in the sense that if the PC is intact on your ASOCT, then very unlikely that you will have a PC defect. Of course, it might be thin, so more careful measures, but you can handle it like a routine surgery.
Yeah, but you should always follow the principle. Even if OCT tell, because PC will be thin, I'm talking of true post-polar like this.
No.
We
have come across about 5 eyes where there is a posterior capsular defect. In that, we did all that we showed. Another observation is that, usually in the posterior polar cataract, the runoff of the rexes is from pole to, the PCR is from pole to pole.
Yeah.
So usually you have 2 flaps of posterior capsule intact. So whether it's a toric intraocular lens or a multifocal lens, very carefully you are able to insinuate them in the support that is available, because none of these lenses come in a 3-piece platform. I'm sure you would have done it.
Yeah.
I'll be covering that in the next session, the talk.
Thank you, chairpersons.
Dr. Purinder.
Yeah. I'll be now, after the good discussion on variety of IOLs, I will be sharing my experience of subluxated lens. So this is my first case, which has traumatic pupillary mydriasis, subluxation of the lens, and there is a presence of vitreous in the anterior chamber. The first thing, bimanual anterior vitrectomy is done. Just stain the vitreous, diluted triamcinolone, and check whether there is any more amount of vitreous present over there. Then you make capsular axis. I use a micro forceps for this, and this capsular axis should be decentered, more centered to the dislocated or subluxated lens. So hydrodissection is done. I am stabilizing the lens with the capsule retractor. One capsule retractor is enough. This will prevent further prolapse of vitreous in the anterior chamber. And I am polishing the capsule, and all the some amount of posterior PCO which is cleared. Now capsule retractor is removed, and I am making a tunnel here which is 2 mm away from the limbus, and this is 1 mm, and a reverse tunnel is also made to embed the proline suture knot there. And with the railroad technique, mind it, while passing this needle you can damage the fragile capsule bag. So that has to be secured, and I am using my iris spatula so that my needle also doesn't damage the capsular bag. Now this is a Sione ring. Multiple knots are tied to the haptic, and Sione ring is pushed inside the capsular bag. Keep the capsule bag distended with the viscoelastic. I don't use any high-end viscoelastic. I use only carboxymethyl cellulose. And the bag is now centered, and a single piece lens is placed inside the bag. And then remove all the viscoelastic from the anterior chamber. Check for the presence of any vitreous in the anterior chamber. These small tags were there, and with the same retractor, with the IA mode, I am just reducing the size of the pupil, and this will decrease the size of the pupil, and that is going to decrease the glare part of this young patient. So this is my first case. Another case, this case, because this is the area of maximum zonal dialysis, and I have to use a double Cioni ring because it is almost 270 degrees subluxation from this part to this part. So again, a capsular access is done in a way which you are comfortable with, and 4 capsule retractors will be placed to the CCC margin, as you can see, and that this will stabilize the lens on 4 parts, and 2 Prolene sutures are used, and this is a double Cioni ring. One can use single Cioni ring and a capsule traction ring segment to stabilize at 2 places, and it is brought in the capsular bag in the area of maximum zonal dialysis, and 2 sutures are tied to the scleral tunnel bed, and the knots are buried. Some problems are there when you remove these, when you tie these knots, because they try to make this thing. The sutures get entangled on both sides, so that has to be kept in mind. So this is the post-op picture of the same patient. But, this is interesting thing. Patient came to us with the 32 years old lady came to us with the decreased vision and myopic correction. So she went to some place, and she was advised a laser correction, corneal surface procedure. So when I dilated the pupil, I found that on pentacam there was no cylindrical power, but here it was -4.5 diopters of cylinder. And some nuclear sclerosis and posterior subcapsular cataract was also there, and there was a subluxation of lens. Then she gave us the history that she had a trauma 11 years back. So we did a laser assisted cataract surgery, and this is the area of zonal dialysis or subluxation. We have to decrease the size of the capsular axis, and we have made it eccentric as it is the demand of this subluxated cataracts. Rest of the technique is similar as we have done it. So in these cases, the subluxated cataract cases, laser assisted capsulotomy and surgery is very, very helpful. And as we were discussing during the first laser based cataract surgery talk in the first go, and then we found that some vitreous was coming in the anterior chamber, so we did a vitrectomy and stabilized the lens bag and puts the Cioni ring inside the bag after distending the bag with the viscoelastic, and a similar technique is adopted. So this is the post-op picture of the same patient, very well stable lens bag, and the IOL well centered, well covered by the capsular axis. There is another case we did in the similar way with the help of laser cataract surgery. This is another interesting case. We have to manage differently because we had had a lot of problems during the procedure. So first, in this case where the bare vitreous is there, you have to fill the chamber and cover the vitreous with the viscoat, and to prevent further prolapse of vitreous in the anterior chamber, and multiple capsule retractors are placed so that the lens bag doesn't get torn at the capsular axis margin by the traction during the phacoemulsification. And this was a dense cataract. As you can see, grade 3 cataract was there, and you can complete it in a routine way. Only thing is that you have to decrease the parameters of your phaco settings, and a Cioni ring is placed. And I was doing in a routine way. When we place the tunnel very close to the main wound, then we bend the needle so that it can pass easily. Now at this place, what happened? Just 30 seconds more. Pulled this lens bag has got damaged on the other side. I have damaged those zonules on the opposite sides also. So on the right side, my zonules were weak, pre-existing weakness was there, and now by the pulling of the suture, I have created zonular dialysis on the other side. And good part is my Sione ring is inside the bag, and then what I did, I released the suture, proline suture, and got a new proline suture with the 2 straight needles. So one loop is passed from within the Sione ring, and then it is tied to the sclera. And there was a PC rent also in this case. Then 3-piece lens is 3-piece lens is placed in the sulcus, and an optic capture is done in the capsular axis because my capsular axis was intact. So this will prevent the lens to fall back in the vitreous cavity because I have engaged the optic of the lens in the capsular axis. So this is the post-op picture of the same case. This is the ovalization, and this is the rent in the posterior capsule. But the lens is stable. So various other cases. So we can do Yamane technique also, we can do scleral fixation, we can do. So this is what it is. So to conclude, this is a good technique. If you are able to complete it, you complete it with this technique. Otherwise, you can do a retro-iris fixation or other kind of lens fix.
Thank you. Thank you.
Excellent presentation, Dr. I'm sorry we are short of time.
Yes, sir.
And the next session, Dr. Titial is glaring at us because he is the chairman of the next session also. So thank you very much, everybody. Thank the speaker. Thank you very much, the audience.
Thank you.
Thank you, sir. Extremely informative session. Thank you so much.
Thank you all the presenters, chairpersons. And next session is also very important. That is the quandary of complex cases. And